Good afternoon, everyone. Welcome to today's meeting of North Somerset Council's Health and Wellbeing Board. So just a little bit of housekeeping to get us started. I know everyone is very familiar with the routine by now, but just in case, we are obviously using Microsoft Teams for this meeting, but they do have the same standing and validity as if we were having a physical meeting. And just to remind everyone that because this is a public meeting, it is being broadcast live online for the literally dozens of people who'll be hanging on our every word this afternoon. We're not quite at the level of certain famous parish councils, so I'm hoping that we won't have any radical controversy during the meeting today. If you could try and remember to mute your microphone when you're not speaking, just so as it makes it a bit easier for everyone to be heard. And please use the chat function or the hands up feature to request to speak if you wish to do so. So we're going to go straight into the first item on the agenda, which is the approving the amended terms of reference and membership, and we're going to do the roll call of those present at the same time. So you'll know that in a report that was circulated with the agenda, there was a proposal to make a slight alteration to the membership of the Health and Wellbeing Board, and that's to include a non-voting member from the Wellbeing Collective, so a nominee from the Wellbeing Collective in North Somerset, who are an important stakeholder in terms of a lot of our health and wellbeing work, and bring together a number of organisations, charities and other groups working on health and wellbeing. So it's really key to have them involved, and I'm pleased that they've put forward Mark Graham to be their nominee, who's joined us today. So I would ask the board to support that change. And in addition to that, one that wasn't on the amended terms of reference, we've also had an approach from Avon and Somerset Police, who would like to nominate someone to serve on the Health and Wellbeing Board. And again, I think that would be a useful addition. So if we could agree those changes, so including a nominee of the Wellbeing Collective and a nominee from Avon and Somerset Police, both as non-voting members of the board. I'll take it as read that we've agreed that unless anyone shouts otherwise, and then I will invite, are you doing the, I don't think Brent's in the meeting, so he can't do it, can he, Leo? So are you going to do the roll call for us, Leo?
Sorry, just unmuting myself. Okay, roll call. Mike Bell, obviously.
I'm present. Yeah.
Catherine Gibbons. Sheila Smith.
Yeah. Here.
Colin Bradbury, I've seen.
Yes, I'm here, thank you.
Matt Lenny.
Yes, I'm here, Leo, and also to let you know that Dr. Kevin Hegarty will be joining, but he'll be slightly late.
Also, Hayley Verico.
Yes, here.
Georgie Bigg. Not present. Paul Lucock, who I've seen.
I'm here. Thank you.
Jeremy Blatchford.
Yes, I'm here, live and kicking.
Okay. Wendy Griggs. Okay. Is that? Did I hear Wendy? Councillor Griggs.
No, sorry, Leo. I can give her apologies because I do know that she's in another meeting at this precise time.
Okay. Councillor Mark Crosby.
Present.
Councillor Kieran Cronley.
Yeah, I'm here.
Sarah James. Not present. Emmy Watts. Not present. Dr. John Heather has given his apologies for today. Dr. Shruti Patel is not here. And of course, Mark, who I've seen.
Yes, thank you, Leo.
Right, that's the complete.
That's great. Thank you, Leo. And if there was anyone who was missed, I don't think there was, so That's that done. Public participation, I think we've got none. Is that correct?
None notified. No.
Okay, and any apologies for absence or substitutions?
Other than John Heather, Dr. John Heather, who I've reported.
Perfect, thank you. Any declarations of pecuniary interest? So item 4. Nobody. Oh, hang on, we've got a hand up. Sheila.
I'm just pointing out that Jeremy's put in the chat that Georgie Biggs needs a link to join Leo. So I don't know if you've seen that in the chat. Sorry, Mike. Thanks.
Just to say, I've sent a link on to Georgie now, if that's helpful.
Perfect. Thanks, Matt. Okay, super. Right. Item 5, then, the minutes of the last meeting. So any comments or corrections in terms of accuracy on the minutes?
Chairman, there is one that I'm aware of. Town Councillor Jeremy Blatchford was shown as being a non-voting member. That can be corrected.
Okay, that's great. So no other comments. So we'll note the minutes from the last meeting and move on to the first proper item of business. So item 6, which is the presentation and report from Georgie MacArthur, our public health consultant, who is leading the development of our health and wellbeing strategy. So over to you, Georgie.
Thank you, and good afternoon.
You're on mute, Georgie.
Can you hear me now? My apologies. It took me a very long time to come off mute there. Sorry.
Yeah, that's fine. And
so
just to say, Georgie Big has joined us as well. So hi, Georgie.
Thank
We're on item 6. So the other Georgie is about to commence the presentation on the health and wellbeing strategy development.
Thank you. Yes, I was just saying this item is about the approach and the aims and the timescale of the health and wellbeing strategy. And the Health and Wellbeing Board are asked to endorse the aims, the approach and the timeline, and also to contribute any thoughts about the strategy, vision, priorities, etc. afterwards. So I'm just going to run through a short presentation which summarises the key points in the paper. Just bear with me a moment. My machine is being very slow, my apologies. Okay, bear with me, it's nearly there. Right, okay.
Just to say, Georgie, it's Matt here. If you're having troubles from your end sharing, do you want me to try from here? Is that helpful?
I think I'm okay, thank you.
Okay.
I think the answer might be no. We had a brief glimmer there, but it's disappeared again now. And you're on mute again, Georgie M.
Sorry, that's me sharing that. I've lost my...
Can you see me?
Georgie, are you...
I'm here.
Do you want me to share it, Georgie?
Yes, we've got you, Georgie Big. Don't worry.
Right, great.
Oh, right.
Thank you.
Sorry, I think I'm off mute now. Yes, if you're able to share, that would be really helpful. Thank you.
Right. Okay. Now I've lost. Right. I'm struggling. I had it right there for a minute. It seems to have disappeared from my list now.
Okay, are you going to have a go, Matt? Next time I'm going to bring a quiz for us to do for the first 10 minutes.
Yeah. Okay, I'll go for the third time and you're lucky, hopefully. Let's see if that works.
Thank goodness for that.
Can people see the presentation now?
Yep.
I think that's coming from my machine.
Yep.
Yep.
Great. Okay. So, Georgie, you give me the nod when you want to go to next slide, and I'll let you lead away if that's okay.
Great. Thank you. Right. Just wait for them to share. Okay, great. Thank you. And apologies for the IT problems there. So this is about the health and wellbeing strategy, which will run from 2021 to 2024. And just by way of introduction, next slide, please, Matt. The health and wellbeing strategy essentially provides a really timely and important vehicle to deliver the action plan for how together we can bring about benefits to health and wellbeing and reducing inequalities in North Somerset. So we'll essentially outline the shared ambitions for improving health and wellbeing and reducing health inequalities. It will highlight priority themes for the key challenges that we want to address. And very importantly, will be a succinct strategy, but have a very focused action plan. So we'll demonstrate exactly how we'll meet those ambitions, who will be doing that, what are the outcomes, and how will we measure success and the timeline. So it's very clear exactly how those ambitions will be brought about. And we'll also take a very collaborative approach, so including details of how we'll work with residents and communities and organisations across North Somerset to achieve these goals. In terms of aims, I've highlighted that addressing the key health challenges will be a key part of the strategy, but of course, addressing health inequalities will also be a central ambition. And it may be that this is communicated through the vision, but also they might feature as a kind of helical theme running through the strategy and action plan, so that in all of those actions, it's not just about improving health, but also how can we reduce health inequalities across North Somerset. And I've just added here a key point that it will absolutely build on all the existing programmes and strategies that are already in place, both across the council and the wider system. So it takes that collaborative approach and avoids duplication. And I've just put a few examples here, but this part of the process will be understanding and mapping all of the programmes and strategies that are already in place that this strategy will build on. In terms of developing the strategy, it will be informed by quantitative data that we have about health needs using the public health outcomes framework, and then more granular local data, evidence for effective interventions. So we have a colleague working at the university who's inputting into this as part of a placement. So doing that rapid scoping and evidence review, so we can be sure that we're using evidence of what works best. Undertaking system mapping, so working with CCG colleagues and others to understand what's already happening across the council and the system, and understanding sort of key stakeholders, what networks there are, programmes, etc. And then, of course, the consultation and engagement process with stakeholders, businesses, residents, colleagues, etc. And so by bringing all of these things together, this will enable development of the themes of the strategy within an overarching structure that enables us or ensures that we consider the early years and the best start in life, thinking about living and working well, so that kind of 25 to 64 year age group, and then aging well for those aged over 65. And I just highlighted that, of course, there'll be the clear action plan as part of that. Next, thanks so much. In terms of the approach, there's some work already undertaken at North Somerset Council about the place-based approach to addressing health inequalities, and this will build on that. The priorities identified through that work were mental health, physical activity, and healthy places. And as I'll mention in a short while, these our consultation so far shows that the feedback is resonating with these key themes so far. We're taking a sort of renewed consultation approach, building on this, taking account of the impact of COVID-19 and making sure we get that timely feedback from residents, stakeholders and others, and understanding kind of risk factors for key causes of premature mortality, morbidity, COVID-19 illness, and understanding kind of how best to prevent and manage poor mental health and mental illness. And in addition to considering kind of the key risk factors for premature mortality and morbidity, the strategy will take into account those wider determinants of health. So not just thinking about, let's say, tobacco, physical activity, diet, but also transport, housing, education, employment, etc. So taking a very broad view of all the factors that influence health that we can address to improve health and well-being. In terms of strategic oversight, I've just put up here the individuals involved in the steering group, and I should say there's a name missing there. Shelley Caldwell's also part of the steering group, service leader East for the community family team and principal social worker. We also have additional practical support from individuals who are on placements with us, who are helping with the evidence review and analysis. And the steering group meet every 4 to 5 weeks to provide that strategic oversight and input. So in terms of the process and next steps, the Health and Wellbeing Board endorsed the development of a new health and wellbeing strategy last September. In terms of the new health and wellbeing strategy, the steering group agreed that a very collaborative approach is required to maximise the beneficial impact and likely success. So focused around that consultation and engagement, enabling buy-in and ownership of the action plan, and bringing into being that a way of working openly, collaboratively with the public, with partners, and building on some of that momentum that we've seen through the community COVID-19 response. And I think this is just absolutely an essential way of working really with the strategy to make sure that it's impactful. Of course, this requires time, so enabling in-depth engagement so that we can really gather a range of views and perspectives regarding challenges, priorities, where there are community strengths already, new opportunities, ensuring that we have time to map the existing programmes, enabling that consultation and engagement, and then critically also accounting for the time pressures of the COVID-19 response. So that's taken a huge amount of time for the public health team, but also for our partners, including the clinical and health professionals that we engage with, and community partners and others, of course. Yes, and accounts for the time diverted from in the public health team to the COVID response, particularly last autumn. In terms of the consultation and engagement, I mentioned previously that that's one strand of work to ensure that we hear from stakeholders, residents, organisations, colleagues, etc. And this just highlights some of the key activities that are included at the moment. There's first of all an e-consult survey. It's actually been extended, so that's actually open until the end of February. And we have a survey for residents and stakeholders. We've had some really interesting feedback so far, which I'll come to in a moment. We've developed a tailored survey for businesses to enable a component focusing on healthy workplaces. We've submitted questions for the citizens panel. We've had 6 online public and stakeholder workshops using a range of methods to ensure that we're promoting the strategy and the consultation. We have 3 evening meetings with the town and parish councils representing North, South and Central parts of North Somerset next week. And consulting with key networks and forums, so North Somerset Together, the Wellbeing Collective, BCSE Leaders Forum, integrated locality groups across North Somerset Council, and of course through yourselves with the Health and Wellbeing Board. And so far we've had some very interesting feedback of some of the key themes which resonate with those identified through the place-based approach, so mental illness, physical activity, healthy diet, and addressing socialisation and loneliness as key priorities identified so far, but of course it's still ongoing. So this comes back to the slide previously highlighting that how additional time is needed to really ensure a greater likelihood of success, and this highlights that updated timescale. So originally it was anticipated it might be published in March. This just highlights how actually taking the consultation engagement activity through to the end of February allows then for a month or 2 of the data analysis, synthesising the themes, developing the action plan, agreeing actions among partners, then moving forward to that development of the strategy and finalisation, approval from the Health and Wellbeing Board, and then looking to publish the strategy in July. So just accounting for or allowing additional time to enable the thorough process to be completed. So in terms of decision, the Health and Wellbeing Board are asked to endorse the proposed approach to developing and delivering the Health and Wellbeing Strategy and Action Plan, the anticipated overarching narrative, and extending the timescales to publication in July 2021, and also invited to comment any views regarding themes, priorities, interventions, strategies in place, any additional points really to be considered that you feel maybe aren't evident in this presentation, and of course supporting the engagement process and championing the strategy however possible. Thank you.
Thank you, Georgie. A really good presentation, and I'm really pleased to see the progress that we're making with the development of the strategy and the engagement and consultation work that's already well underway, which is great. So I've got Jeremy Blatchford first. Remember, if you want to speak, please do flag that either in the chat or by raising your hand. So Jeremy.
Yes, thank you. I thoroughly endorse everything you just said, Mike. One thing that is causing concern is the awareness of the planning department. I heard an unbelievable statement at a planning meeting, at a town council planning meeting, and I've had a lot of complaints. Somebody suggested that, people would hear vehicles coming along the road, so they didn't need a footpath. Unfortunately, the person who's saying it didn't realise that Amazon now have electric vans increasingly, and people won't hear. I've had some very, very rude comments. So do you think you'd like to make sure they're aware, please? It's embarrassing. I like the smile, Mike.
Thank you. Thanks for that, Jeremy. I wouldn't expect Georgie or Matt to comment on that, but I think actually it does illustrate one wider point, which is, and definitely comes through in the guidance for health and wellbeing strategies, which is that integration across all services is really critical. And I do think there is a valid concern that I can probably say this safely because there's nobody from our place directorate in this meeting, I don't think. I'm not sure that always we're as joined as we should be in terms of planning and placemaking and some of those place-based decisions in council when taking into account the health and wellbeing issues. So I think that's a really good challenge, Jeremy. Thank you. Kieran next.
Hello. Yeah, so my kind of questions are around us. Obviously, as we kind of come out of COVID and things, is there still a risk around the timeline slipping, or is set the date set? Is that pretty reasonable? And kind of the observations really. I know you're going to come to HOSP anyway, so you'll get views of HOSP, but definitely support the things around mental health. But there's also an element here as well around kind of healthy childhoods, because we know children quite impacted by all of this. But fully support what you've said, but just kind of the timeline. How much at risk is that?
Thank you, and I think it's still an ambitious timescale, but one that we can meet. And my time is very much focused on this from a sort of leading it forward. So yes, I agree it's ambitious, but I think it's doable. And I think as the vaccination programme moves forward for COVID and things change going forward into the spring, hopefully, that will allow for more time among all of our partners as well. And I totally note your points about mental health and healthy childhoods. It's interesting actually because early intervention and prevention is also is being identified as one of the key themes. So yes, absolutely something to be taken into consideration, that kind of early intervention, a focus on the early years. So yes, that is something that we'll be taking into account.
Great, thank you. Matt, you want to come in?
Thank you, Mike. Just quickly to say a big thank you to Georgie and Charlotte, who's also on the call, for all their hard work in pulling together the consultation process and leading a group of interested people to try and work our way through this. So thank you for that. I guess one of the things that I was reflecting on as we were talking about it is the importance of the action plan that accompanies the strategy. It's really important that we have some clear priorities and some measurable difference about what we're going to try and do. And I suppose the other thing I'd flag up to members of the Health and Wellbeing Board is I think some of that is also having a resources plan next to it. So we're looking at within public health about how we might be able to refocus some investment around the priorities as those become apparent. And I think across all of our service areas and across all of our organisations, how can we use existing commissioning or look for new opportunities to have an effect, particularly on health inequalities? So how do we proof our services so that they are genuinely trying to close the gap for those people who are suffering poorest outcomes, and we're making the best possible opportunity of chances for prevention and early intervention as well. So I think that's something when we come back to the board, we'll be interested in people's views about how we can line up our resources most effectively. So that's all I wanted to say. Thank you.
That's really helpful. Thanks, Matt. And I noticed that Seb has posted a question in the chat, which is also asking about alignment with the wider sort of Healthier Together and CCG programmes as well, which I think is a good challenge, and also North Somerset Together and how the work that we've done there on the COVID response. So any thoughts on that, Georgie?
Yes, so we led a kind of health and wellbeing strategy specific meeting with North Somerset Together last week. So I've heard all of their thoughts and working closely with Richard Blows to ensure that it's very much linked in with North Somerset Together. So yes, it's very much part of the thinking.
And I was going to ask actually about, so I was interested to note that in the guidance it's expected that the CCG and the local authority should be equal partners in the development of a health and wellbeing strategy. And I do think there is a risk, isn't there, that it becomes seen as being something that belongs to the council rather than to the community and all of the partners and stakeholders. So do you think there is more that we can be or should be doing on that? And I wonder if any of our CCG colleagues want to comment on how they feel the process has gone so far, and do they see themselves as equal partners in its development? Matt's got his hand up, so maybe he wants to deal with that first, and then Colin's smiling, which has got to be a good sign.
Yes, I was just going to say that I do think the development strategy is quite a complement to the overall development of the integrated care system. So if we're thinking about that as the health and care system responding to population needs, but with a health and wellbeing strategy giving a specific focus on North Somerset as a place, it will identify the priorities as all partners that we can think about we want to try and affect. So it will help to take that ambition and put it into some measurable actions. And in the same way, then we wanting to work with our localities, which are looking to become integrated care partnerships, so that we have it at a kind of system level, we have it at a place level for North Somerset, and then we have some of our practical operational stuff really working well together in our two integrated care partnership areas. So I think it can help going up and down, if you like, in terms of being meaningful. That was anything I was going to say. Thanks.
Thank you. And Colin?
Thanks, Chair. I mean, and just firstly to answer your question that you posed originally, then I think we do feel very much involved in the JSNA work and the work that Matt's team's been leading. And I suppose the only thing I was going to say is that we understand very well the challenges in Western and the health inequalities, but I also wonder if there's more work we could do to sort of dig into some of the issues in the north of the patch, which perhaps don't get the same attention in some of these exercises. Not necessarily about now, because we know outcomes in terms of health are genuinely good in the north of the patch, but what are the things coming down the pipe? So if we were to look 5 to 10 years forward and we carry on doing things we're doing now, what opportunities do we have to try and future-proof some of the work we're doing today?
Thanks, Colin. Yeah, that's a very good point, and certainly from the council side, we would be, in political leadership, we would absolutely be keen to see this as a strategy for North Somerset and not for little bits of it. I think the caveat to that, I guess, is that clearly one of the issues that we do want to address front and centre in terms of the strategy is it is addressing that inequalities gap.
Of course,
and we obviously do recognise that it's not only Western by any stretch, but obviously there are particularly acute challenges in Western. So Matt and then Kevin.
Yeah, I was just going to come back on that point and just agree that we do need to think about the whole population. And I suppose there's elements of burden of need that we need to think about. So if we think about key challenges like frailty, you know, how do we encourage healthy aging as a concept, particularly for the North Somerset, where we have an older population, and there will always be significant challenges there. How do we take the pressure off our health and care services, do strengths-based approach, try and work on our assets, that type of thing? And there's huge benefits for everybody in that, not least the individuals and their families and their communities, but also, for example, in children as well. When we think about children's mental health, when we think about childhood obesity, these are, you know, prevalent across the whole of North Somerset, and they are things that we need to be deeply interested in. How do we disrupt those patterns of need and harm to children and young people, because we know that some of those patterns set early in life will last a lifetime, and that diminishes the quality of life. So yeah, I agree. I think we will have those, because we've got the life course theme of the early years, the working years, and the healthy aging. There will definitely be things in there for everybody, and some of those fundamental challenges will be addressed, as well as the important extra focus on those communities that require additional support.
Thanks, Matt. And Kevin next, and we were joined by Kevin Houghty, who, just as he promised, arrived just slightly late.
I'm so sorry. Yeah, so I mean, I'm just going to agree with everybody, really. I think there is important to have a North Somerset offer, which is a generic offer, and also recognising that there are pockets of deprivation in Woodspring, particularly, you know, around Pill and other areas. But I think we do need to have that special offer for that deprived community in the centre of Western. You know, the inequality gap, I think, is likely to have been widened with post-COVID. There's lots of initiatives, lots of opportunities. It's how we make sure that we sort of coordinate everything. And certainly for Western, I think it is around that One Western, which is the integrated partnership group that we're trying to set up. Well, we have set up, it's been going for a year. Is to try and make sure that we're focusing all our efforts and not duplicating and wasting resources.
Thank you, Kevin. And I think I almost am sort of tempted to go back where we came in, which was Jeremy's point, where he was having a little dig at planners. But actually, I think that for me, why this strategy is so important is that it is about, and it is the principal route through which we will be able to properly join up some of the interventions that we're doing around economic development, transport, infrastructure, local plan, with some of those developments that are happening in terms of health and care systems as well. And it's only by joining those things together that we will really tackle those wider determinants of health, won't we? So I see this strategy as critical, really, to that longer term project of shaping the community and the health and well-being and care services that we provide to meet the needs of the population. Okay, Jeremy, you want to come back in? Have another go. Go on.
Yeah, very quickly. One thing that does stand out is the very small pockets of deprivation in rural areas, which may amount to 2 or 3 houses. And we literally have the situation where people in a village have got executive jets and God knows what else, and you've got other people who are really scratching around, and the key is transport. And I leave it at that.
Yeah, thank you, Jeremy. Good point. Okay, so I've got no one else who's indicated they'd like to speak. So just thank you again to Georgie and the team for all the hard work. It's great to see so many stakeholders involved in terms of the steering group with the strategy, many of whom are on this board, which is fantastic. And I think my plea would just be, please, see this as a process of evolution over the next few months, and please do get involved. Please do go back and share some of the evolving themes and ideas with your organisations, and try and get us to a place where we've got the best strategy and action plan at the end of it that we can. Brilliant. Okay, thank you very much.
Chairman, could I just quickly, there were a couple of recommendations in the report and presentation. Can I take those as carried? This was one to endorse.
I think so, yes.
Yeah.
I don't think there's any dissenting voices, so unless anyone shouts now, we'll take that as read. Thank you, Leo. Okay, so next on the agenda, item 7, which is the update on COVID response. So I think, Matt, you're going to just give us a quick overview, and then obviously it would be great for CCG and other health colleagues to chip in from their experience in terms of, you know, hospital pressures, where we are in primary care, vaccinations, and so on. So over to you, Matt. Thank you.
Okay, just bear with me. I'm just trying to see if I got the right. The irony is being able to share my screen with somebody else, and I'm just trying to make sure that I can share it for the item that I need to present. So just bear with me a moment. Right, okay. Right, I will hopefully get that to share now.
Yep, I can see it.
You can see it, can you?
Oh yeah, it was there.
Again, sorry. Right, there we go. That's hopefully it now.
It's back.
And apologies, it's got the wrong title on it. Is that okay, Mike? Can you see it now?
Yeah, perfect.
Great. Okay, so I'm just I'll run through this quite quickly because I don't want to speak at people. I suppose at the start I would be asking people to think about a couple of things really. So we could sit and reflect a lot on how well we've responded and lots of things we've done, and I think there are a lot of examples of that. But I'd be particularly interested in the board thinking about what do we think we could be doing better and should be doing better in terms of managing the COVID response, and also what do we think the changing situation, where might the challenges come to us as we look ahead to next week when we're likely to get a national programme of releasing lockdown. So maybe people could think about those things as we go through, and then I'll pick up those questions at the end if that's all right. So just very briefly, in terms of the information about where we are on rates, well, this is old information because this was shared a few days ago. Just to give you the latest, the numbers in North Somerset at the moment are overall population rate is 90.7 per 100,000. So that's the lowest it has been for some time. And that compares to a Southwest rate of 96 per 100,000 and an England rate of 142.8 per 100,000. So we are below both the Southwest and England average. And in our over 60s population, we're down to 57.2 per 100,000, which compares to the Southwest of 67.6. So again, below the regional rate. So that's good. It's good to know that North Somerset is doing relatively well in terms of our case rate. But I suppose it's back to the point that those are still relatively high numbers. And although they've come down significantly from the peak of over 400 per 100,000 in kind of early middle of January, we still have a large number of people who are still contracting COVID on a daily basis, somewhere between about 20 and 30 people a day. So that's still an area of concern, and we need to think about how we bring those numbers right down and make that a more manageable total going forward. So that's one element. In terms of testing, we've continued to have good testing access in North Somerset through our 3 PCR sites, so at Bristol Airport, at Locking Road and at Castlewood in Clevedon. And the R rate is below 1 in the Southwest, and the latest national study, the Imperial College study that came out today, said that alongside London, the Southwest was one of the areas with the greatest reduction in terms of rate of COVID transmission, which is encouraging signs. And just an update on the positivity of tests. So this was one of the key tests when the original tiering structure was put in place, where the threshold of below 5% of all tests being positive was seen as an important step. So we've gone lower than the numbers within this presentation. So we're down to 3.1% positivity in North Somerset at the moment, compared to 3.4% for the Southwest and 6.4% for England. So again, encouraging signs of things moving very much in the right direction. And our age rates as well, they're quite similar to the rest of the Southwest and slightly below the England average. I guess the principal challenge for us maybe is in the 25 to 44 age group. And it's something about working age adults. There's still a higher rate of cases in that group. And I guess that might be something we want to reflect on in terms of, what might be happening in that group. Are they just out and about more because they have to work? But also, are there challenges around people isolating? So that group may be circulating the virus more, and quite possibly unknowingly through asymptomatic transmission. But it's a bit of a challenge about how do we make sure that everybody can respond in the same way to becoming aware of symptoms, testing, and isolating effectively. In terms of the work streams, this is quite a busy slide, but it's just a helpful way of seeing all of the different programs together. So it's just recognizing that the response has gone across a number of different areas of work. So outbreak management is about how we support our settings in terms of clusters or larger outbreaks of cases. And big tribute to my team here in terms of within public health. We've worked with colleagues in Public Health England, colleagues in the CCG, in Serona, in adult social care, in children's services, wherever it might be, to support places like our care homes, our schools, and workplaces. And we've seen a reduction in the number of notifications, which is great. We've seen some good response from the wraparound of those different agencies to support those places. And of course, paying tribute to the individual leadership in care homes and schools and workplaces in how they've tried to risk assess and support their staff or people using those services. But that's been a significant challenge to deal with the sheer number and complexity of some of those issues. In terms of testing, I mentioned about the testing for people who have symptoms, which has been in place for some time now. We've also had to develop our lateral flow testing offer. So some of that is done directly in settings, but we also have community rapid testing now through sites based in Portishead, in Weston-super-Mare and Nailsea. The last one opened last week. And those are 7 days a week, and we've included evening openings on Tuesdays and Thursdays to try and make sure that people who do have to go out for work have an opportunity to understand whether they may be carrying the virus, but unknowingly carrying the virus. And for every person that we can identify, we can help lift them out, isolate them successfully, and contact trace around that individual to reduce risk of transmission. We've also had to set up an enhanced contact tracing service, which is currently being run by the public health team, and we're looking to recruit more people to be able to support that service. We found that's been helpful because we've been picking up people who have not been contactable by the national test and trace service. 24 hours after they've not been able to make contact, we pick those people up. The fact that a call's coming through from a local number and from a local member of staff seems to be helping to get through to some more people. We send text messages to encourage people to be available for a call later in the day, for example. And we found out a lot more about what's been some of the challenges for those people, and being able to successfully signpost those people to practical support and more guidance and more explanation around the things that they need to do and how to do that effectively. So that's early days, because that only started in January, but so far it's also been quite a useful form of soft intelligence about issues around particular outbreaks or clusters of cases. So we continue to try and use insight and communications approaches to connect with different groups of people to identify what support they might need to carry out the protective behaviours and bring down some of the barriers. We also try to brief stakeholders regularly and build that community response capital. So the more that we can keep people informed as early as possible, say for example in the area of the business community, proactively giving them information, explaining new regulations, giving them tools to implement safe practices in their workplaces makes a big difference. But alongside that, we also have enforcement roles. We do try to encourage and explain as far as possible, but where it's needed, we are taking action against people who are resisting those messages and are fairly obviously doing things that they shouldn't. So that might be directly through our regulatory services teams, or it may be alongside the police, or police may be enforcing that work. But what we have done is build a good intelligence network amongst those enforcement agencies, and we've complemented that with the development of, through the Marshall's Fund money, community support approach, where we're out and about with more eyes and ears in the community, and proactively engaging with workplaces and in particular locations where we know there are more issues. We've also used the surveillance and intelligence. There's a lot of information. We're trying to turn that into true intelligence, where it's leading the approach, understanding more about where there may be issues and acting on that. And then the last two are kind of big programs where obviously there'll be other members of the board who will be able to talk a lot more about these, but just highlighting the sheer effort and logistics and the hard work of colleagues in the NHS and the volunteers supporting them to roll out a vaccination programme in double quick time and to achieve such good rates of coverage in North Somerset as part of the BNSSG approach is fantastic. And also the incredible response from our community organisations, the way in which people have come together and that really active work to identify community need and to make sure that the community voice comes through and that we try and make things more relevant and we use the assets and the know-how in our communities. That's telling us a lot about not just responding to COVID, but how we do things in the future, which I think is really important, much more about networks rather than sort of linear approaches. We need to be more organic and more responsive to where our community can identify and carry out solutions. So just on the vaccination, so it's just sort of saying that there's a lot of stuff going on there. Some of this data is a bit old, but the numbers have gone up. I think more like 180,000 at the end of last week and moving into the next cohorts. And we also have our different sites within the mass vaccination centre, all of the great work within primary care to develop new access points, both in terms of GP practices and one of our pharmacies as well. And then it's just kind of reminding ourselves that through all of this, there's been an incredible response within the health and social care system. So whilst doing outbreak management, testing and setting up a vaccination programme, there's also been significant pressures in all of our systems, both in terms of acute community providers, primary care and our social care provision as well. Thankfully, it looks like we've gone past the peak that came at us in late January, early February. But the demands still remain high and the pressures are significant alongside the usual winter pressures. We've tried to develop creative approaches using the multi-agency kind of way of working to make sure that we've got better prevention measures in place and we can respond quickly. We need to try and think about how we prevent people going into hospitals and get out of that setting as quickly as possible, and that demands all kinds of creative solutions. And then looking ahead, I suppose it's thinking about our longer term health and care impacts. So we've already talked a little about around the health and wellbeing strategy, mental and emotional wellbeing, but there'll also be significant challenges around deterioration of physical health, because some of the interventions or the early diagnosis might not be happening in the same way. And then we need to think about the wider context. We also talked about wider determinants of health and wellbeing here and how that's impacting on inequalities. So, what is happening around our child development, building up future needs? What about the impact of worklessness, not just now, but potentially when furlough may end? And I know that's a live topic in the media today. But also people like informal carers, what's been the impact on them of caring for people over such a long period of time in that type of pressure. So I'll stop there and maybe just kind of remind people that it'd be really good to hear reflections on that whistle-stop tour of some of our response and what we need to do next in terms of being effective for our community and making sure that we're making the most of all of our resources and our partnerships to tackle things effectively going forward. So I'll stop there.
Thank you, Matt. Really good overview as ever, and as I say, I will invite CCG and health colleagues to chip in and contribute their thoughts. But we've got a few questions first. So Mark Crosby, Councillor Crosby.
Oh, thank you very much, Chair. I thought it was Catherine before me, but right. Matt will recall that I contacted him about, I think, 3 weeks ago regarding a local company that had come to me who specialised in work for the MOD and aerospace and therefore had been described by their customers, so to speak, as essential. And they were trying to find out how they could be part of the on-site lateral flow testing regimes that were beginning to be developed at that point, and then discovered, very helpfully with Matt's input, that actually they needed to employ 250 people and they only employed 70. So 3 weeks or a couple of weeks later, that regime changed and it became a minimum of 50. I'm just wondering, is there more that we should be doing in terms of on-site testing for those that have to work? And the other day I walked past an estate agent's. There were 5 people in the office and so forth. So I'm just thinking from that point of view of that 25 to 44 age range, for those that have to work, it's an excellent place to begin to test them. They're all there, and it's within a manageable space. Is that somewhere where we should focus more effort and attention? Thank you, Chair.
Want to deal with that one first, Matt?
Yes, of course, I'm happy to. So yeah, it is a challenge, and I suppose one of the challenges we have here is Department of Health and Social Care has overall responsibility for the testing system. So it's asked us as local authorities in double quick time to set up the community testing offer, which is based on sites rather than individual delegation of tests down to workplaces. They do have the workplace program as you described now. One of the challenges is around so the manufacturers of the tests have certain conditions that they consider to be appropriate for accuracy of the tests. So you have to have a level of training and a sort of, I suppose, a level of operation for them to be deemed to be effective. So when you go down to individual organisations or individual workplaces, that can be more problematic with a small workforce to have somebody who's able to administer it appropriately, having been trained. But I know the Department of Health and Social Care are looking at this in terms of recognising, especially as we move into a period of unlocking, we're going to have all kinds of venues which are going to have more people in them. And it would make sense to take the tests to them rather than ask them to go somewhere else if they're naturally going to be there anyway. So it's something that we keep representing back up to the Department of Health, but there are some challenges around the efficacy of the tests unless you do them in certain circumstances with certain control measures around them, I suppose. So it's getting the balance right between convenience and being confident that you're probably getting a good result out of the test, because otherwise the risk is that people get false negatives and get a false sense of assurance that I've had a negative today, therefore, even though they're given the instruction to continue to practice the COVID safe behaviours, you do get some elements of where people perhaps get false confidence around what they can and can't do because they've had a negative test. So it's a challenging environment, especially when we are giving people different messages about different types of tests. So you've got to try and keep people with you as you go along that route, but it will be an ongoing challenge, and you raise a really important point here, and it's one that we keep debating with the Department of Health, and as and when we come up with better solutions or they give us more tools to be able to do that, I'll be happy to have another chat with you. And by the way, if there are any issues about COVID secure behaviours in workplaces, then do feed those through, because that's something where we can ask people to go and have a look at that and see if we can advise them on better practice. Yeah.
Thank you. I agree. It's from the point of view of until they give us the tools, but I think that this sector is going to come back and keep biting us until we've dealt with it in far more forceful terms. Thank you, Chair.
Thanks, Mark. Catherine next. Sorry, I went to Mark first because he said he was leaving early and I wasn't quite sure.
I thought I was being punished for joining late. Apologies for that, but I wasn't sent a link. So I was watching on YouTube and desperately trying to get in. I just wanted to ask a question around vaccinations. I note the high percentage of over 80s and over 75s, 93 and 88% that have had a vaccination. I just wonder, do we have any data as to why it's not 100%, i.e. what is the percentage of people who are actively refusing a vaccination? And as we move down into different age groups and cohorts, do we suspect that might become more prevalent? We've all seen in the press that there are certain communities that are very suspicious of the vaccination. We're also seeing reports of companies operating maybe in the future a jobs with jabs policy. And so I'm a little bit concerned that there may be communities that could be disadvantaged and prejudiced out of jobs because of the difficulty in persuading them to take up the vaccination. So just wondered what your thoughts are on that.
So I don't know if NHS colleagues want to pick that one up in terms of the vaccination programme. I mean, I'm happy to say a bit, but you guys are running it, so
Colin's flagged. So
yeah,
give it
thank
a go,
you.
Colin.
On that point, so it is a really important question, and we've been doing analysis as we go, as you would expect, of the take up and if there are any patterns. What we've not detected so much of so far is any sort of concerted resistance, and there will be individual reasons if someone is sick or otherwise not available as to why we haven't got 100% coverage. What we have found more evidence of, though, is particular areas of our patch where take-up is lower, and they tend to be areas of lower social economic status and deprivation. So I think there's more, we're focused more at the moment on ensuring equality of opportunity and supporting people to come forward and get their jab, rather than any concerted vaccination skepticism within the patch. But of course, we're not complacent to that, because as we know, that is a factor. So we'll continue to monitor for that. And as I said, I don't have any granular data to hand, but I've certainly received briefings that gave us confidence that we know where coverage is poorer, and it does tend to be concentrated in areas of higher social deprivation.
I think that's is that okay, Catherine?
Yeah, thank you.
I think that's a really interesting point, actually, and it does prompt a further point on the vaccinations, because I think, it feels to me that the comms message has been quite good in terms of particularly, some of the groups that might traditionally have been resistant to vaccine take-ups. But I think that issue of economic deprivation maybe hasn't been picked up as strongly. And it just leads me on to a question that maybe you can also help with, and then I'll come to you, Hayley, sorry. It is, Colin, which is about the vaccine sites, because I do wonder, one of the challenges that we get as elected members is, why are there not local vaccination centres? Why have we got to travel somewhere else in order to do it? And I think particularly in Western Town Centre, for example, one of the questions has been, well, when there are buildings like the Town Hall and the Winter Gardens and places like that, why have I got to go to Whirl or to Ashton Gate in order to get a vaccination? So I'd just be interested in what you think about that, because I think that might be part of the mix in terms of that more economically excluded communities who not only might be a bit more resistant anyway, but will clearly have some more challenges in terms of transport and access and so on.
Yeah, absolutely, and I think that's why we've tried to get a plurality of different venues, not only the big centres like Ashton Gate, but also pharmacies, for example, and that isn't always possible depending on some of the logistics. I think the most important factor is that the first vaccine to become available, as you know, Pfizer has a very specific and quite complex cold chain storage requirement. So certainly in the early days, we had to find sites that were set up and could quickly sort of handle that sort of distribution of what was a quite unstable product comparatively. As other vaccines come on stream, and Kevin will be able to explain this far more eloquently than I will, that does give more flexibility in terms of local GP surgery coverage, and also going out to people who are, to use the old-fashioned term, housebound, to be able to vaccinate them on site. And the government have made further financial support available for primary care to be able to do that. I don't know if, Kevin, there's anything you want to add on that particular.
Yeah, I think we are using Horizon as a vaccination site, aren't we? So, and Colin's quite right. We couldn't use that straight away because of the complexities of the first vaccine that came out. But we're using Horizon, which is very accessible. And I think with the socioeconomic deprivation, it is a matter of access. I think that is the key. So they often transport, the costs of getting to sites is an issue, and also the time frame. Sometimes we give people very narrow time frames to attend, which if your life's a little bit chaotic or you've got shifts and things to do, you can't fit in with that. So having a local access centre is really important. But on the whole, I think the vaccine is being taken up very well by the population. We haven't seen many people. I've had a few conversations, but a tiny number with people who are a bit nervous about having it.
Thanks, Kevin. So Hayley next, and when you're making your observations, Hayley, I wonder if you wanted to, without wanting to become obsessed with vaccinations, I wonder if you want to just comment on the take-up of vaccinations amongst adult social care staff.
Yeah, that's just what I was going to do, Mike. I've got the data with me because we're having to report it to the Department for Health and Social Care on a weekly basis. And it is Adult Social Care and Contracts and Commissioning who have coordinated the response with all of the care sector. So many thanks to those staff for doing that. The latest data that we submitted on yesterday actually shows us that 71% of domiciliary care staff have been vaccinated. We've had a coordinated effort with the providers and certainly around vaccine hesitancy. And the feedback that we're getting is that a number of the domiciliary care workers generally are young females, and they are concerned about having the vaccine because they do want to start a family. So that's one of the significant reasons that's come back to us. The take-up of the vaccine in residential care home staff is really good. It's currently at 78%. And 87% of care home residents have been vaccinated. What I would say in response to Councillor Gibbons' query is in regard to the vaccination for care home residents, it's recommended that you don't vaccinate when a home has got an outbreak. And so we know that there are a few homes where the GPs will be returning to complete those vaccinations. I don't know if you want to say anything more about that, Kevin, but that's the advice that we've been given.
No, that is correct. So there are, I think there's a handful of homes. I think the vaccination rate is pretty good in the homes. And we've done the large number of the population who are housebound, and I think they were a particular risky group because they often have multiple carers going in. So we've done the bulk of that population as well, which I think is really good. Yeah.
And in regards to our own frontline staff, Mike, 80% have been vaccinated.
Excellent. Thanks very much, Hayley. That's really, really good news. Sheila next.
So there were just 2 points I wanted to raise following on from Matt's presentation, which I thought was really useful. One was around vaccinations and one was around the recovery bit. So on the vaccinations, I just wanted the board to be aware, because I think it's only reasonable that Matt and I are experiencing a very high level of concern from early years providers in particular around the fact that they do not have access to the vaccinations. So I just wanted the board to be clear that we at a national level continue to make representations around the wider education workforce, and particularly when you link it to the hoped for return from the 8th of March of children back into education, and the fact that early year settings have been open throughout. It would be useful, I think, if the board were able to just support the fact that we, when the government and the joint committee re-look at the prioritisations when they've gone through the first priority groups, that they do consider, those providers, it as a cohort that we might need to be prioritised in order to get the economy going and also get children back into education. So that was my first point. And my second point in terms of recovery was also to flag I think in terms of the board going forward, it may be useful for us to think about how our children and young people do get back into education, and particularly over the summer and the recovery period, and us needing to be cognizant of their mental well-being really and their emotional recovery. So one was about vaccine and the wider education providers, and the other one was just around that recovery of young people in education terms.
Thanks, Sheila. I don't know if you wanted to come back on that particular point about the early years and vaccines, Colin.
I did, thank you, Chair, and note Sheila's comments about the great contribution that early years staff have made throughout this lockdown period, which I know we'll all acknowledge. And just to underline the point, of course, that the Joint Committee on Vaccinations, the JCVI, which sets policy for the country, are continually weighing up the emerging evidence as to how we may better prioritise different groups. And of course, if you prioritise one group, by logic, you deprioritise another, because there is a finite number of capacity to deliver the vaccine, as we're all aware. So I know that those sort of difficult balances are being regularly reviewed at a central government level, and we will of course continue to follow the guidance and the science as it emerges.
Thanks for that, Colin. And certainly, I think everyone is sympathetic to the case for those that have had to continue to work and put themselves at risk. So particularly teachers, early years staff, some of the other public services that are not in the vaccine priority list but have continued to put themselves at risk by continuing to work. So I think everyone is very sympathetic to that. I mean, what I've been keen for us not to do is to try and go off-piste in terms of the national priority list, because I think part of the difficulty that's been caused by this whole process has been where there's been mixed messages in terms of what's been going on. And we heard that at our Outbreak Engagement Board, didn't we, earlier in the week, where there was some confusion about whether in Bath and North East Somerset early years staff had been offered the vaccine, whereas in BNSSG they hadn't. And this, uncertainty doesn't help, does it? So I think absolutely the right thing, as Sheila has outlined, is to make the case to national government and to the Joint Committee, and hope that they do update the priority lists accordingly. Okay, who have we got next? Kieran was next, I think.
Oh, yeah, thank you. So just kind of reflecting on the 24s to 44s, I think you're probably right. It's because they're having to go in and work. And I'm just really mindful that Bristol is obviously a key area for some of us to work in. And obviously Bristol has the Bristol variant, which they're trying to stamp down on. Do we have contingencies in North Somerset in case the worst happens with regards to that? And just the other bit, just to mention the age category before that, if you need any help with messaging or anything like that, Councillor Hugh James and I can help as youth champions. So it's just an offer really if you need us for that earlier age category.
Thanks, Kieran. Do you want to come back on that contingency planning point, Matt?
Yes, and first of all to acknowledge, thank you about the offer of support in terms of reaching out to the key age group. Thank you. I'll have a chat with you offline about that. So in terms of contingency planning, yes, we have been doing that. We've been looking and learning from the experience of colleagues in Bristol and South Gloucestershire, where they had to stand something up very quickly in terms of surge testing. So partly that's through the Department of Health and Social Care provide mobile testing units. So it's about providing a site for that, so people can drive up, get their test and then go away. They've also used libraries as places where people can collect kits, go home, do the test themselves. The challenge has been the returning of some of those kits. I know that the numbers given out are not matching the numbers coming back, but there still are many thousands of people using these routes to do testing. The other thing we've looked at as well, because of our rural nature within North Somerset as well, is options around mobile testing. So we've looked at things like our Mavis bus, which goes out and does a lot of community safety work. We've got mobile libraries, we've got other vehicles that could be used as well. And the good news is they're temperature controlled, because one of the problems they had in Bristol and South Gloss was they were trying to get tests out at a time when it was very cold. and these tests can be affected by that type of temperature. So just when you think you've got a plan, there's another complication quite often. But so we have done a bit of planning around that with our colleagues in the Place Directorate. We've got different options ready. We've learned from what Bristol and South Gloss have done in terms of how they manage their coordination through their strategic command group and then the tactical group that pull together the actions. So yes, we have a template, I suppose, but the challenge with the new variants is you're not quite sure where they're going to arrive. You're not quite sure how you draw the circle around it in terms of where testing will be meaningful. So we need to have options rather than set plans and then adapt as we get any information about. And the routine surveillance is constantly looking and new places are being added. But we would be ready to stand up if that's what we need to do.
Thanks, Matt. And the only other thing I would add is that it's worth noting that we local health and local authority partners don't necessarily always get loads of advance warning when these surge testing or other measures are put in place. So, for example, in terms of the recent measures in Bristol, I think the first that many colleagues heard of it was when it was announced by the Secretary of State in the House of Commons, rather than any significant preparation time. So it's always very tricky. Okay, Kevin's next, I think. He's not seized his moment, or has he? No, he has.
Kevin's still muted. Oh, no.
Sorry, I am sorry. I got a phone call in the midst of that. I'm so sorry. It's just a few reflections, Matt, about that younger working age group. There's been a big difference from the first wave in a strong element of denial when they present to primary care. They seem to deny the possibility that they could possibly have COVID, even though they've got a cough and a temperature. And I think it's teasing out why that might be, and it probably is to do perhaps with the economic implications, or just the implications in terms of their lifestyles and their children and things like that. But that community seems to be having an element of denial. And the other reflection really that we're seeing, which is a worry to me, is over the year of lockdown, we've seen a big deterioration in metabolic health. So a big deterioration in HbA1c, a marker for type 2 diabetes. So that population are becoming significantly more unhealthy. And I would expect that the most challenged communities would see that happening much greater than the more middle class, wealthier communities. A lot more pre-diabetes being diagnosed as well.
Thanks, Kevin. And I've got Georgie next.
Sorry, Mike, that was related to something earlier. I'm just looking for the whether or not there was any data on the take up of the Riverbank site, when we were talking about, trying to make sure that the more deprived populations were getting their vaccinations. I know some of the feedback that we've had is that, a taxi ride has taken 20 minutes, and that's if you can afford it as well. So I'm wondering what impact that has, and do you have any figures on the take up there, and whether or not that the distance has had an impact?
So I think what the critical thing, that message for colleagues who are in control of these things, and unfortunately most of them aren't on this call, are they, in reality, is that I think there's a really big appetite for information and data. I hear that a lot from residents as well as from stakeholders and opinion formers. What's going on? How many people are being reached? How effective is it? And I think it's been a bit of a mixed picture in terms of how well individual practices and primary care networks have perhaps communicated what they've been doing. So I know that, for example, Mendip Vale have been really good in terms of giving a running commentary of how they've been doing it day to day, and I think that's been really positive. And I saw some figures yesterday from Peer Health talking about, you know, reaching more than 20,000 vaccinations this week, which was really positive. But I think, you know, the message should be the more we can share that information and data, the better, because I think it helps to reassure people about the reach, but it also gives us some understanding about some of the challenges that we've still got and how we can best address them. Colin.
Thanks, Chair. Yes, and acknowledge the point, and just to obviously say that there has also been some requests nationally that we manage some of these messages, and so it hasn't always been within the gift of local services to be able to give really granular detail, because I think the government understandably wants to try and make sure that we give a sort of coherent picture rather than things coming out in a sort of a very sort of local level. So we are, I think, getting to a better balance of that, and perhaps one could argue that to start with the message discipline was too tight, and that's created a dearth of information in some cases. I think the good news, not to, for a moment to deny that it's really important that every single person gets the opportunity to be vaccinated, but you know, for the first priority groups, we are in the high 90s, you know, pretty much across the board, so that will benefit everyone, because of course the risk of transmission is therefore greatly reduced with that level of immunisation. That's not to be complacent, and that's not to say that people shouldn't still practice the hands, face, space messages and what have you. But it is the I think will give some reassurance to the board that the level of vaccinations that we're achieving so far is very encouraging and will benefit everyone, regardless of their individual status.
Thanks, Colin. Hayley next.
Yeah, I suppose it's just flagging it to this group, Mike. In recognition, and as Matt said, the care providers in North Somerset have been through a really, really difficult year. And despite the fact that we've supported them with grants, just over £10 million has been paid to providers in the last year, and significant numbers of PPE. And we've just allocated some additional workforce grants to them. But some of our providers locally have now got less than 60% occupancy. And to be financially viable, they need to be running at about 95%. So that is just a flag here, because I'll be bringing some analysis around what we need to do to support the care homes on a temporary basis. Because we are still in winter pressures, and there are still significant pressures in the acutes. So to just tell them to go away and manage on 60%, we just can't do that, because we have got a duty to ensure their financial sustainability. And the other issue I wanted to raise, as well as Kevin said about people's physical health, we are also seeing an increase in mental health contacts, especially in the younger age groups, and also the number of informal carers who are really struggling with their mental and physical health. And also the latest one, which we've just begun to speak to the CCG on, is long COVID, where we are seeing some people who are really, really struggling. And these are not necessarily people who have been into hospital because they've been so poorly. They're just younger people who are really tired and fatigued and really struggling to get back to full levels of independence. And the other category that I just want us to be mindful of is people who have been waiting for operations for quite a long time. We're seeing an increase in requests for packages of care for people who are waiting for hip and knee surgery, who ordinarily would have coped, but some people have been waiting for more than a year. So I really just wanted to flag those issues in terms of recovery. Mike?
Thank you, Hayley. Very, very important and valid points to make. And I think there's issues there that we're going to need to return to again and again over the coming months, aren't we? Catherine.
Thank you. Just backtracking to Georgie's comments about people having difficulty getting to the vaccination centres, and thinking possibly we need to reinforce the message that there are voluntary groups that will do this. I mean, I myself, as an NHS responder, have driven a number of people actually into the Bristol vaccination centre because they've been there. And I know that North Somerset Together has quite a strong network of people across the district. So if someone did struggle and wasn't able to pay for a taxi, there is that help. So perhaps we need to liaise a bit more closely to make sure that that message is getting out there. And just to pick up on what Hayley just said about long COVID, I mean, this does concern me. I'm already hearing, and I've met people who are suffering from this, and I would just wonder when we are going to have to alter our workplace practices, as it were, to take into account the nature of this disease, because remember all the difficulties people had in getting ME recognised as a genuine illness, and it's another post-viral syndrome, and yet that caused an enormous amount of stress to people. This is much more high profile, but I think we have the time to act and make sure that we recognise this and people's prospects in terms of employment aren't impacted.
Thanks, Catherine. And Colin.
Thank you. Just on that last point, I wouldn't comment on the employment side, but certainly in terms of the phenomenon of long COVID, that is clearly recognised, and the CCG is commissioning pathways to deal with long COVID sufferers. Of course, by its very nature, we don't really understand the long-term impacts of it, but the post-viral fatigue and other such conditions, we are clearly putting pathways in to support that. There is such a wide variety of those symptoms, though. I think there will perhaps not be just one single long COVID service. There will have to be a number of different factors addressed, and will also hopefully, I think, benefit people who've suffered from other long-term post-viral effects, which is, if I'm honest, isn't a patient group that we've been particularly comprehensively serving. So there may be some benefit to others who haven't had COVID but have had similar symptoms in terms of fatigue and other sort of ongoing health conditions as a result of post-viral fallout.
Thank you, Colin. Okay, so we've gone through all the questions there, I think. So thank you, everyone. That was a really good discussion. Lots of good points and issues flagged there, and I'm sure that I speak for everybody on the board when we reiterate again, enormous thanks and appreciation for everything that all the colleagues across local government, NHS, primary care, volunteers and beyond have been doing in terms of the COVID response. We've clearly not got everything right, but I think that the willingness to get stuck in, try and tackle things, and go the extra mile in every respect imaginable to try and support people through this has been extraordinary, and it's really pleasing, particularly on the vaccination programme and all of the health protection work that we've all been doing to see the impact of that. So thank you. Okay, so we'll go on to item 8, which is the SEND peer review. So I think Sheila, you're just going to give us a quick overview of where we are with this one.
Yes, I am. Thanks very much, Councillor Bell. So some members of the board will be aware that back in 2018, we had an Ofsted and CQC inspection of our services to children with additional needs and their families. And we got a written statement of action, which identified a number of areas where we, in particular, the local authority and the CCG needed to make significant progress. By January of last year, we'd been having regular monitoring from both the Department for Education and NHS England and Improvement, who were giving us both support and challenge, and we were expecting our re-inspection. However, we then had the pandemic, and of course all inspection activity ceased, and so as a result of our general children's improvement journey, which began last year, we as a council decided that it would be useful to have peer challenge from the Local Government Association. We went ahead with this with the agreement of our colleagues in the CCG, because quite clearly the services for children with special education needs and disabilities is a shared responsibility across both our agencies and many providers whom we commission. So we commissioned the challenge, and I've set out in the report that we asked them to look at 4 themes: the impact of COVID on the business as usual, but also critically on our improvement work. We also wanted them to comment on issues from parent carers' perspectives, not least because that was an area where, as an area, we'd gone through quite significant change in recent years with different representatives from the Parent Carer Forum. So we wanted to see how that had either been strengthened since the LJAR, but also the impact of COVID on that as well, and the quality of co-production, because that was an area where Ofsted and CQC said that we needed to undertake more work. The relationships with health partners, we've identified that there were areas there that were in our action plan, and again we wanted to have a benchmark about, okay, how well were we doing. And then finally the 4th area was around the quality of our education, health and care plans and how the respective responsibilities are working out. So just to say to you that as of today, and it's often the case, today I received the final report back from the LGA peer team, but obviously it was far too late for it to come to this meeting. But I will say that this report is based on the draft findings. The challenges that anybody gave back to the draft were fairly minimal, and so these recommendations remain. So you'll see there were quite a few around governance and leadership, which I think are quite key, capacity, the effectiveness of EHCPs, because whilst they saw there was an improvement in the standard of that, they were concerned that our previous near enough 100% compliance with the timescales had dipped quite considerably during COVID. So if I go back to the start of the report and say that what we're asking for is for you all to have hopefully read this report that does give you the preliminary summary, and to consider how the board could support and influence positive outcomes. I think one of the particular things here is that the CCG are here, and I anticipate Colin wanting to make a comment statement on behalf of colleagues in the CCG. But I guess one of the key governance issues is the peer review team were very clear that we should link this to our children's improvement activity overall, and that we should link the SEND programme board to the Children's Improvement Board. And I just wanted the Health and Wellbeing Board, it's a lot of boards, isn't there, to have the opportunity to give feedback, to give challenge if necessary to CCG and the local authority, and then to determine, and I guess it's a question for you, Chairman, about how you'd want to keep track of this, being mindful of the fact that the Children's Improvement Board, which is a multi-agency board, and it has the Department for Education there as well, how we sort of don't trip over and duplicate, but nevertheless retain a focus on how we do need to improve our collective services. So I'll leave it there if that's helpful.
Thank you, Sheila. I think that is really helpful, and you've given us a very good introduction to the conversation, really, because for me the role of this board is to provide some critical challenge both to the local authority and to the CCG and to other partners that we've got around the table. And this is the principal forum that we're able to do that, because we have got the wider health and wellbeing community represented here. So I think, for me, the questions are, how are we going to deliver upon those recommendations? And I think there are some very specific ones in terms of, for example, levels of funding of services from the CCG, for example, and in terms of some of the governance and leadership arrangements that the local authority makes, that certainly as a board I would like answers to, and I would like sight of how we're going to achieve those together in the future as part of the action planning process. And I do totally agree with what you say, that we don't want to duplicate conversations and debates that are happening in other fora, I absolutely do think that we need to keep a watching brief on this, and I want to see that those critical recommendations are being taken seriously and implemented by everyone represented around the board. Any comments or observations from any of the board members? Georgie.
One of the key areas of our work, of course, is the co-production area, and I would like to offer that from a Health Watch perspective. We're working with service users and their families. I think we can, we can obviously build that into our work plan, because it's a really important area and something that doesn't come up in volume, but obviously of importance.
Yeah, absolutely. Thank you, Georgie. Sheila.
Oh, there we go. Sorry, muted and unmuted. So I was just going to say thank you very much to Georgie for that, because actually I think the other thing to bear in mind here, Georgie, whilst you're right to say it might be smaller in number, actually your Health Watch report, which probably now is getting on for 2 years ago, in relation to young people's mental health, is also quite key to this debate, because certainly, and the original action plan does also have on challenges around us being able to respond to children's mental health, and I think that is, that continues to be a challenge. Although I'm aware through conversations with Colin that hopefully the CCG is making efforts to level up, if you like, the services that we have in North Somerset. So I think, Georgie, linked back to that work from Health Watch, and maybe something more focused that we could reasonably bring in alongside the Parent Carer Forum, who are themselves very much in this space. And I would, Chair, I'd just like to draw attention to board members that some of our members, and I include Councillors Gibbons and Bell in this, do have regular meetings with some of our parents who I think find that really useful. I know they've had one meeting with health colleagues, senior managers, including the chief executive of the CCG, and I think that all that element around that co-production and that respectful listening and then going away doing something about it is really key for all of us to take away. So sorry, that was a bit of a long-winded response, but I just thought it was important to say, yes, Georgie, thank you for that offer, and we'll take it up.
Thanks, Sheila. And Colin, next, please.
Thank you. And just to sort of reiterate and underline some of the points that have been made, that co-production is so important, and really understanding and listening to people about what is important to them and their children. Also to sort of stress that it is a high CCG priority to ensure we improve the services that are the subject of this report. And as Sheila, we know we've had meetings between the executive and the CCG and their equivalents in the council to look at how we can work better together on that. The other thing around funding, which is always an issue and does obviously helps. We are investing more, as people will know, in children and mental health services, for example, but there's more to do. Sometimes, though, it's not only about funding. And there are analogies here to the physical healthcare provision we commission in the hospital, in that there are additional investments that go in to the Western area in particular, but they're sometimes taken up by the costs of locum and interim staff, which are necessarily more expensive. So we're paying more to get really to try and stand still because the recruitment challenges to certain parts of the service, not all of them, but certainly some of them, will be well understood and rehearsed. So it's not always about funding, it's about how can we build a service offer that is not only meeting the needs of the population, but is also attractive to draw in staff who are in high demand across the whole country. And that's one of the challenges I think we're wrestling with, as well as all the other things that have been highlighted so far.
Thanks, Colin. So in summary, it feels as though there's good words in terms of our shared commitment to try and deliver upon these recommendations and further refine our SEND action plan to implement them. I suppose what I want to see is more detail about how we will do that collectively across the system, whether they're short-term or longer-term interventions that are going to solve it, and I totally recognise the challenges around ensuring that we've got the appropriate professional expertise and as well as the funding required to attract that professional expertise. But certainly what I would find really positive is to get an update in terms of that action plan in due course, and then we can hopefully fulfill our responsibilities in terms of challenging and scrutinising both the council and health partners in terms of the commitment to deliver upon that. But I think particularly I would say the recommendations are quite clear, aren't they? So I think it would be really good to see that action planning process come forward sooner rather than later. Catherine.
Thank you. Yes, I was just going to say that I found the peer challenge a very valuable opportunity to sort of reflect on everything we do. And I just wanted to make a very simple point when we talk about, co-production and, parking partners together and all the rest of it. What I hear from parents is that they perceive everything they need to do for their child as a battle. And we all know that being a parent is stressful enough, but when you have a child with special needs, and I know because I worked for many, many years with the Children's Hospice Southwest, and that's a whole other dimension, but it's that I just want us to work towards, bear in mind, all of us, when we're working on this action plan, to try and get that feeling of battle away from the parents, so that we are working together to achieve the best for the children. They're not having to fight us to get what is their due. We want to work together. It's just a very simple point, but I think it should be key.
Thank you, Catherine. Okay, so is everyone happy that we've covered this one off, and do you think you're comfortable and clear, Sheila, in terms of what feedback we would like in the future as the board? So I think as far as I'm concerned, I think it's clear that we expect the Children's Improvement Board to be driving this agenda and overseeing this work, but I think we do need some regular updates in terms of progress on that, and particularly where there is a need to, for want of a better expression, bang some heads together in terms of local authority and health leadership. I think that's where the Health and Wellbeing Board would absolutely see its role.
Yeah, so just to say, Councillor Bell, I've put in, oh sorry Georgie, can I just, is this all right? Yeah. I just put in the chat, so what I was going to undertake was to say that absolutely have it on the agenda at the next meeting, but in the meantime I'm happy to send out the finalised peer challenge report alongside the action plan, which also goes back to the written statement of action and the LJAR. So I just warn people, it's the peer review is not, but the action plan is hefty, but I think it's important that you see it. If you want the Real Idiot's Guide, it's rag rated down, so provided you're not colourblind, you'll be able to get where the issues are, but I will send that out in between now and the next meeting, so I hope that's acceptable, Chair.
Thanks, Sheila, that sounds really useful, and sorry Georgie, I thought that was an old hand.
it was just I wanted to thank Sheila for reminding me of our original report, which was a long while back, but to say that it is still ongoing. It's not been lost. It's part of our key work at the moment and is top of our list. Okay, on our work plan, it's not disappeared. Thank you.
Thanks, Georgie. Okay, so that's a really helpful discussion again. Thanks Sheila and team for bringing that to us, and we look forward to getting that update report then in due course. Okay, so the final item on the agenda this afternoon is the integrated care system development. So I believe you're going to talk to this paper, Seb, and thanks for joining us and sitting through our discussions. So over to you, Seb.
Thank you, Chairman. My name is Seb Habibi. I'm from Healthier Together, so I work for the partnership that's delivering health and social care across Bristol, North Somerset and South Gloucestershire. And it's been a pleasure to be here this afternoon, so thanks very much for inviting me. I've really enjoyed the discussion, and if you'll have me, I think I'd like to come back. I'm here to talk about the next phase of development for our integrated care system. I've circulated a paper that I won't go through in detail, but I will pick out some of the key points for you before opening up to discussion. And I should flag that since I circulated this paper, the government in Whitehall, no less, has published a white paper setting out proposals to introduce legislation into Parliament this session about integrated care systems. So I wasn't able to cover that in the paper itself because it went out before that publication. But I did want to end with a nod to that work and potentially open up an opportunity to come back and talk about that in further detail, because clearly that is going to be important for our partnership. So I imagine people will know a bit about our partnership, but I don't want to assume too much. I'm going to start at the beginning. So Healthier Together is a partnership of 10 organisations planning, commissioning and delivering health and care for the whole of Bristol, North Somerset and South Gloucestershire. In my appendix, I set out some details on that. It does include North Somerset Council and also Bristol City Council and South Gloucestershire Council as well, and includes all the NHS statutory bodies that are operating in the area. It includes the GP collaborative that represents all 81 of the GP practices in our area, and also an important partner in Serona Health and Care that leads the delivery of our community services. We've been around since 2016, so you could say we've been developing as a partnership to improve integrated care and improve outcomes for our population since then, and therefore we have been working as an integrated care system all that time. What's happened in the last few months is that we've gone through a process as a partnership to get some recognition for the progress that we've made in collaborative working and the achievements that we've made, and we've been designated. So in a sense, we've got the badge now. We're officially recognised as an integrated care system nationally as of December. And there's a letter attached to your paper that sort of sets out, some of the evidence that we summarised to support our designation, which is signed by the chief executives of all our partner organisations, and it reflects what we've done together on planning services, on pooling our resources to commission services, on working together on transformation programmes in areas like mental health, acute care, integrated care, and it reflects in particular the kind of accelerated progress that we've made together in facing down the COVID-19 pandemic over the last year in particular, which of course has been an immense collaborative effort which accelerated transformation and delivered some really important results for our population. So we've now got the badge. And this programme is now into the next phase of development for our integrated care system. So how are we going to evolve our collaborative ways of working for the next phase of our development journey to better serve our ambitions for our population? So the last bit of my page one was about how we've sort of framed our ambition. I've already had some feedback that the language in this could do with a bit of work, so if you bear with me on it. So I'll pick out one sentence in particular that I hope will resonate, which is that we've set an ambition to increase the number of years that people in our area live in good health, to reduce inequality in health outcomes between social groups, and help to create communities that are healthy, safe and positive places to live. So developing our integrated care system is about how we can evolve the way we collaborate to better serve that purpose in the next phase of our journey of working together. So what is that about? What is collaborating in an integrated care system about? On my page 2, I've highlighted 6 principles that the local government association have set out, which I think really resonate, as well as 4 development themes from NHS England that I hope also resonate. So the local government association has emphasised that developing as integrated care systems is about collaborative leadership. It's about subsidiarity, so making decisions with and close to our communities. It's about building on the successful local arrangements that we already have in place. It's about a person-centred and co-productive approach, a preventative, asset-based approach, and it's about achieving best value. Other things that NHS England have added is that it's about providers working in collaboratives, it's about commissioning becoming more strategic, it's about the development of those partnerships in places, and it's about good use of digital and data to drive more effective working and collaboration as well. I'm going to move on and talk about the next steps of the programme that we've mobilised in our area and how we're going to engage with partners to develop a set of agreements between our 10 organisations about how we're going to work together in the next phase. We're quite near the beginning of that process at the moment. So I set out a diagram on my page 3 that talks about kicking off with engagement of all of our partner organisations. So we've got workshops with all of our partners happening in February and March. And the first one was with North Somerset Council the week before last. So I've seen a few familiar faces from that event here today. So thanks for all the feedback that we've received so far. It was a great kick-off session. So the first phase is about engaging with partners and sort of building that sort of sense of, well, what do we want to achieve in the next phase, and what are the important opportunities that we can grasp together, but also what are some of the risks and issues that we need to manage and address together. After the engagement phase, we'll be into a period of developing our agreements together, working in partnership, if you like, on the content, developing some specific propositions for agreement. And this is an example of why I'd love the opportunity to come back and keep talking about this, because as some of those propositions emerge, it would be great to engage with the Health and Wellbeing Board to test some of that out. And then we go into a third phase, which is about governance. It's about agreement of these propositions between our partners. We hope to be able to formalise those agreements in a memorandum of understanding that will be underpinned by some supporting frameworks. I've set out in a table from page 4 and 5 some of the areas of agreement we think that the memorandum of understanding may include. I won't go through them all in detail, but it's likely to cover things like how we structure our system for the next phase, how we govern it, how we ensure that we're able to discharge our accountabilities as individual partners, as well as strengthen our collective responsibility for the things we strive for together. Therefore, it will be about things like how we commission together, how we deliver together, how we engage our population together, how we allocate resources, and how we manage risks together. Supporting frameworks are about some of those functions that we will increasingly perform together, we hope, and some of them will build on things we already do together. So developing a population health outcomes framework, developing and improving our approach to performance management and quality improvement, developing and improving our approach to financial management, communications, and OD. The timescale for this work is to be completed by September. So the engagement phase really motoring through February, March and April, the kind of development of the content through April, May and June, and then a kind of governance phase from July through to September. I said I would just make a nod to the white paper that the government has published before opening up. So the white paper that was published on the 11th of February has set out proposals to introduce a bill in this Parliament that would bring integrated care systems onto a statutory footing. So there would be a new NHS body, no less, again, I say a new NHS body established called an NHS integrated care system. It will have a board. We expect the NHS organisations in our area to be kind of de facto members of that board, and that will work alongside a partnership board, very much like we hope the partnership board that we've established since 2016 and is kind of holding the ring on the leadership of our Healthier Together system right now, and we hope into the future. The further details of that legislation are yet to emerge, and we watch with interest, but it's going to get into things like how do we constitute those boards, what new powers do we have to collaborate through things like joint committees, and how does that better enable us to do things like joint commissioning, and in particular what enabling powers does it give us to delegate what we do to a place level? And that's perhaps the theme I want to end on. That, you know, I've talked about developing our partnership and collaborative ways of working. Yes, it's about working at a system level across our whole area, but it's also absolutely about working at a place level. And there's a real opportunity in our area to build on the excellent work of our localities, two of which are, of course, in North Somerset, as the kind of footprints for those place-based partnerships. And we very much hope the legislation is going to further enable us to delegate responsibilities for decision making, resources, and integration of service delivery into place-based partnerships within a framework that allows us to maintain appropriate line of sight and, of course, accountability for that which we're accountable for statutorily and to our populations. So I'd like to stop there, Chairman. Really happy to take any feedback. I'm particularly interested in what people think about opportunities that we might grasp, risks or issues that we need to manage, or questions, you know, that we need to log and make sure we address one way or another.
Thanks, Seb. Really helpful overview. And can I just also say, you know, thank you to CCG colleagues for coming and talking to a group of elected members and officers recently at North Somerset, and just really going through this in some good granular detail, which was I think really helpful. And I think we were guinea pigs for that process, so that was a good experience for all of us. Okay, so I've got the first comment from Mark Graham.
Hi, Seb. That's really helpful. I'm new to this board, so this might be a very naive question, and apologies for that. I don't see where the VCFSE sector is in this section at all. I mean, I can see where it said possibly coming in later at the integrated lower levels, but at that level there seems to be no community input. Just a question, really.
It's a really good point. When our partnership was established, in my humble opinion, working at a system level, at least, rather than a more local level with the voluntary and community social enterprise sector, was a bit nascent. It's really accelerated in the last year, and I've been party to a number of conversations that suggest that we'd like to reopen that question of membership, and get to a position where, you know, the voluntary community and social enterprise sector are formally represented at a system level. And of course, at a local level, at a place-based level, the opportunity is to build where we have got much better, I think, you know, and more mature partnership working with the voluntary sector to build on that, but also to formalise that in these place-based structures that we think will be provided for in the new legislation. So I hope much more to come on that. Thank you for that point.
Thank you.
I think it's an interesting point that you raise as well, actually, because it's one that sort of vexed the partnership board and the joint meetings, because the health and wellbeing boards, Mark, across BNSSG have regular joint meetings as well, to try and tackle some of these more system-wide challenges. And I think the issue about voluntary and community sector involvement is a key one, because I think that, you know, it's so integral to the whole process, and yet it is not always clear at what point and at what level that the sector is represented and the voice heard. And I think because there is an aspiration to transfer more funding, hopefully, in the direction of the voluntary and community sector, I think it's really important that you're, you know, round the table and the voice is heard. I'm just going to come to Catherine, but I think the other issue for me about this process is also around what is the role of health and wellbeing boards and, you know, democratic accountability as part of integrated care systems, because I think, well, to be honest, I'm not sure that the current democratic accountability is very good in terms of health and wellbeing. I've said this many times privately, you know, I feel that I go to CCG meetings and I'm not sure who I'm really representing. Am I representing myself? Am I representing my health and wellbeing board? Am I representing my local authority? I think it isn't very clear, and as we integrate more and we see more joint working and more joint decision making, I think getting those accountabilities really crystal clear is going to be important. And I think particularly for the voice of a community like North Somerset, you know, whether it's the community at large, whether it's the voluntary sector, whether it's the local authority, we need to make sure that we're articulating that voice clearly and that the accountabilities are clear. And I think, you know, you will know, CCG colleagues, from attending meetings like this, it can be difficult and frustrating and confusing in terms of some of the decision-making processes. So I think that's something that we really need to nail down as part of any joint arrangement, so that everybody is clear how they can influence things and where responsibilities for decision-making lies. Catherine, do you want to come in?
Yeah, it was kind of actually picking up on what you've just said, and that kind of clarity about this has to be communicable to people, I think, because what we come across as counsellors, especially with the NHS and any sort of changes, is a huge degree of suspicion when they see any sort of change in the services, even though it's something positive like this. And when we had the workshop session, this issue about communicating what the difference will be to a patient or a resident in terms of the care that they're going to receive. How will it be better? How will it be different? What's it actually like now? And that sort of thing. The other question I had, I know it's a bit wide ranging, but it's a wonderful aspiration, and we all have it, to reduce health inequalities. But how do you overcome the challenge that people would say, how can you reduce health inequalities without reducing all the other inequalities in society? You know, because people become unhealthy because of poverty, because of lack of opportunity, because of poor housing. So, you know, just how are we going to do that when we haven't addressed everything else?
It is.
If anyone can answer that.
Yeah. I think we have to do both of the kind of tackling of the wider determinants piece, which is our long-term, wide-ranging agenda, as you say, Councillor, as well as look at the way we respond to need and demand differently. So I attended a citizens' assembly in Bristol a couple of Sundays ago, and you know, we were talking about this, and you know, and people were saying to me, so why do we do the things the way we do them now? And it's essentially because in healthcare we're quite a reactive service, aren't we? And you know, we kind of treat the demand as it presents, based on almost purely and simply clinical need. And if we continue to do that, then that pattern of meeting need is going to repeat itself, isn't it, Councillor? And now, perhaps more than ever, there is an urgent case to look at that and say, is that right? And do we have to, you know, maybe grasp the nettle of making decisions that kind of balance those priorities with other more population health driven priorities? And I guess the opportunity to do that together and be united in doing it is a strong one, and the opportunity to utilise our data to understand the implications of not doing it, as well as the opportunities we can take in areas like diabetes prevention, for example, and vaccinations. Yeah, are things I think we can do whilst also focusing on the long term, but it's not easy, is it?
Can I just come back very, very quickly and ask, do you think, in an ironic sort of way, that this pandemic and the focus it's given people on healthcare and on what they need to do can be used to advantage in the future?
I do. I'm hesitating because, of course, the health and care service is so fatigued and distressed at the moment, and the backlog in the short, perhaps even short to medium term, is so significant that it's probably going to feel harder to address some of our strategic challenges than ever for a little while. If I'm honest, I think that is the reality. However, I do think the engagement with the public, I do think the opportunities to recruit into our workforce, the opportunities to work with volunteers are greater than ever.
And the opportunity for people to take a degree of responsibility for their health, as they have done through this, through the mask wearing, through taking care. It's just a different mindset that we can perhaps get embedded in people.
Yeah.
Thanks, Catherine. Colin and then Matt.
Thank you. I'll try to be brief, Chair, because I'm very conscious of time. But I mean, just to respond to Councillor Gibbons, I mean, of course, we all know that the NHS on its own will never account for the majority of health outcome. Those reside in other things such as the education system, employment, housing, etc., etc. But what we can do is use the resource we do have within a health and sort of wider care system more effectively and more efficiently. So I don't think this can be a silver bullet to solve all of society's ills, but it certainly could be the case that we would be able to, I think we can do a lot better job of trying to integrated services, because one of the things we get fed back from patients a lot is how services don't talk to each other, and they just seem to be, you know, pushed from pillar to post and telling their story multiple times and not seen in a more joined up and holistic way. So I think what this legislation proposal tries to do is go with the grain of that. And the other thing, just to pick up on the voluntary sector comment that was made earlier, we're really keen to, through COVID and through these changes, is to try and to use a sort of jargony term, demedicalise our system as much as possible, because there are a lot of expensive and low value yielding interventions that we do, that actually if we could think more imaginatively and more laterally about how the whole person could be supported better to get the outcomes they want, it may not involve invasive medical interventions. And I'm sure if Kevin was here, he would agree wholeheartedly that we need to pare back the sort of doctory stuff to where it can be most effective. No, thank you.
Thanks, Colin. And Matt?
Yeah, I was just going to sort of make the same points. I think it's also about how we demonstrate what would be interesting, a bit of an acid test for the ICS implementation and our health and wellbeing strategy, is how much have we moved resource from acute end of need into prevention and early intervention. Because if we do that bit, we will start to impact on inequalities, but we have to make conscious decisions, possibly, to spend less on shiny, complicated stuff in hospitals and more on community-based interventions. And I think in terms of the pandemic, one of the things that has been really powerful is that we've possibly stopped thinking about systems and agencies, and we've started to notice communities and how powerful it is to understand need in communities and the power of intervention and solutions in communities, which don't need a whole pathway or a formalised structure sometimes. You just need to encourage and support people to do the things that they instinctively want to do, and help those people who are less able to reach into those sorts of networks to find ways to do that. So I think the challenge on us is to change our way of thinking, as well as our system, you know, our policies and our processes. We have to be much more open door in working with people to find those solutions, which comes back to our health and wellbeing strategy where we started. That's what we're going to try and do.
Super, thanks, Matt. So I've got no further hands up, so we'll round off that conversation here. I mean, thanks really much for that update, Seb. And obviously this one's not going to go away, is it, in terms of continuing the development of the ICS and obviously how the health and care paper comes down the track and the implications of that for us all. So we look forward to discussing this further at future meetings jointly and as a single health and wellbeing board. Great, and we've got nothing else left on the agenda. I'm afraid that I have failed in my chairing duties and we've used up all of our allotted 2 hours. So we'll try and do better next time. But thank you everyone for attending this meeting, and thanks for your enthusiastic engagement in the issues that we've had on the agenda today. Have a good rest of the week.